Welcome everybody to our Tiff Talk. We have a very special edition today called the Clinical Edition. My name is Andrea Millers and I am with Endogastric Solutions. I also have Karen Gerd here with me, a marketing manager at Endogastric Solutions as well. And then we have two special guests that we're very excited to introduce. We've got Dr. Glenn Eide and also Dr. Patel, my apologies. So welcome everyone and thank you for being here with us this evening. We're very excited to dive a little bit deeper into the clinical aspect of the Tif procedure and GERD altogether. So before we start, I want to remind everyone this is live. So at any time, if you have any questions, please feel free to type them into the comment section and we will do our best to answer those questions today. So before we start, I do want to give an introduction and a little bio of our physician guests that we have tonight. We are live here, if you've noticed, we are live here at Baylor St. Luke's Medical Center at the McNair campus in Houston, Texas. And we have the great honor of having Tif Patel here, who is Associate Professor and Director of the Center for Advanced Endoscopy at the McNair campus here at Baylor College of Medicine in Houston, Texas. His gastroenterology practice includes special interests in interventional endoscopy and medical education. Welcome, Dr. Patel, and thanks for being here.
Thanks for having me.
We appreciate it. And we also have Dr. Glenn Eide. Dr. Eide is a board-certified general surgeon at Matagorda Medical Group, an affiliate of Matagorda Regional Medical Center in Bay City, Texas. He is involved in several professional organizations, including the American Medical Association, the Texas Medical Association, the Society of American Gastrointestinal Endoscopic Surgeons, the Society of Laparoendoscopic surgeons, and the American Society of Metabolic and Bariatric Surgery, and the Texas Association of Bariatric Surgeons, where he previously was the president, right?
That's right.
Thank you. He has authored and co-authored more than 13 publications, 9 of them which are related to the Tif procedure for reflux. Right?
Thanks for that.
Thank you. The latest actual clinical papers, most recently, are the Evolution for Tif, which was published in April of 2020. In addition to that, he has the pH scores in Hiatal Hernia repair with Tif, published in March of 2019.
Right.
Right. Perfect. Thank you. So again, thank you for being here. We really appreciate it. And we're going to go ahead and start and talk about GERD. So maybe we'll start with you, Dr. Eide or Dr. Patel. What is the scientific explanation of GERD?
Go ahead.
So, GERD stands for gastroesophageal reflux disease, which is when the things that you eat and drink and go down into the stomach, but then it comes back up into the esophagus and can cause several symptoms. Heartburn is probably the most common one. Regurgitation is probably the one that most people complain about most bitterly. And then there's a whole host of other symptoms that come from those two, trouble swallowing, cough, clearing the throat, those sorts of things.
Right. Do you have anything else to add?
Well, one thing I like to add when talking to patients about GERD is, it's a common misconception that a patient may be making too much acid. We always think it's, we eat something that produces a lot of acid.
Right.
That's very rarely the case. As Dr. Eide mentioned, the issue is really the acid that normally exists in our stomach refluxing back into the esophagus, and that's because our body has a built-in mechanism to prevent that, but that mechanism can stop working, and that's what we'll talk a little bit more about here.
Perfect, thank you. I do want to also mention, you'll notice we have two physicians here, but we have a general surgeon and a gastroenterologist. So that's going to become important when we talk a little bit more about Tif in detail, including what we call C-Tif. But let's go ahead and talk a little bit about when a patient is suffering from GERD and or thinks that they have, acid reflux, what are the things that you guys do to determine if a patient actually has acid reflux or GERD, there's a lot of tools that you could use, such as the Hercule Questionnaire and the RSI. But I'll let you talk a little bit more about that, and maybe Dr. Heidi,
Sure.
or both of you.
Hey, as a gastroenterologist, this is a very common patient encounter, heartburn and reflux. So the first thing we want to do is really carefully characterize the symptoms. Heartburn has almost, become almost part of our popular culture, if you will.
Sure.
It's, this kind of thing. And so we like to really sit down, and that's where you referenced a scoring system, which allows the patient to rate the severity of a number of symptoms that we know are related to GERD. And that does two things. One, I think it really kind of, makes the condition feel legitimate.
Right.
I think over the years we've often sort of dismissed GERD or heartburn as being something that's normal even.
Right.
And so we start with that, and it also gives us a baseline.
Sure.
So after we've done an intervention, we can kind of not just rely on our memory of how things used to be. It was better, maybe a little better, but we can really use data points to compare before and after.
Yeah.
And then, of course, there is diagnostic testing. The symptoms are, typical symptoms are typically predictive of true GERD, but we will use some basic diagnostics. And the most common thing is endoscopy or upper endoscopy.
Okay.
This is using a flexible scope through the mouth, and it allows us to examine the esophagus, the stomach, and critically that junction between the two.
Yeah.
And so during the initial endoscopy, we'll look for the presence of a hiatal hernia. We'll hear from Dr. Heidi a little bit about that, as well as any of the consequences of reflux. We talked about the symptoms, but there's also actual physical consequences, such as irritation of the lining of the esophagus.
Sure.
And some even permanent changes, such as Barrett's esophagus.
Okay.
So that will give us a lot of good information to kind of assess where the patient's at on the GERD spectrum.
Yeah, yeah. And I actually we have a tool that we usually give most of our physicians. It is the Gerd Hercule Questionnaire, but can you maybe, Dr. Heidi, explain what does Hercule stand for? Talk a little bit, but yeah.
Sure. So Hercule is health care related quality of life. For this survey, it's GERD or reflux quality of life. And there's really kind of 4 sections to it. There's a heartburn section, there's about 6 questions. There's a trouble swallowing, 2 questions. There's a bloating section, and then there's a regurgitation section. And again, that's about 6 questions. So it creates a score which has been validated. It's a validated survey, meaning if it's a positive score, then yes, you do have reflux, and that leads to the interventions and the diagnostics that Dr. Patel was talking about. And then the other one is RSI, which is Reflux Symptom Index. That's more for what we call the atypical symptoms. So when people have reflux, it sometimes gets up into the throat and the neck, and they have hoarseness, they have cough, they have clearing the throat. Same thing is it's a validated survey. So what you have to understand about that survey, though, is that it has to also have typical symptoms.
Right.
If you don't have typical symptoms, the atypical symptoms may not really be reflux.
Okay.
The most common one is cough. So there's 100 things that cause cough, right?
Right.
But if you have typical symptoms of reflux, there's about an 80% correlation rate.
Okay.
So that if they do treat the reflux, 80% of the times, the cough will get better. You may still have a cough from other things, but at least the reflux component of the cough will get better.
Right, perfect, thank you. And we actually just launched a new patient app. It's called the GERDhelp mobile app. And if you look on the screen right now, you can scan the QR code. And if you do that, you'll actually have the Hercule Questionnaire that you can see and go through and answer the questions to see if you are actually a candidate, or not candidate for GERD, candidate for Tif possibly, but if you can self-diagnose to some degree, whether or not you truly do have GERD or not.
At least you know the symptoms would bring you in for possibly an evaluation.
Right. Perfect. Thank you.
I'll
Yeah.
add something about the diagnostics.
Yeah.
I often will see patients who've previously been evaluated,
Yeah.
whether by primary care or even a gastroenterologist, and they'll say, well, I had an endoscopy and it was normal. Well, that doesn't mean you don't have GERD.
Okay.
And so that's where we do have sort of the next level or layer of testing.
Yeah.
And believe it or not, we can measure functionally how much acid reflux someone is having.
Right.
And that's called pH testing. That's where during that endoscopy or later on, a small capsule is placed in the lining of the esophagus, and that actually records, gives us a recording of the number of times acid is refluxing up, whether they're standing up, laying down, really in-depth information. And then we use that to correlate it with symptoms as well. So that's actually become a pretty routine part of my evaluation in patients. But it is a caution that a normal endoscopy doesn't mean you don't have GERD.
Yeah.
In fact, it may mean you're a pretty good candidate for TIF.
Yeah.
Yep.
Okay. Fantastic. Well, thank you. So next thing we want to talk about a little bit more is about the Tif procedure, obviously. Maybe Dr. Patel, you can talk about the Tif procedure. We do have an animation. Do you want to talk about it first or go through the animation?
Well, we'll just give a little background and
Yeah.
then we can switch to the
Perfect.
animation.
Okay.
So, I like to, I'm a simple person, so I like to think
like
of
that.
things simply. And like we discussed originally, the body is already designed to prevent reflux. And just imagine between the esophagus and the stomach that there's a little gate. And when you eat, the gate opens up, or the food kind of pushes it open. And just like those doors that swing back on themselves should swing back.
Right.
And that's what prevents things from coming back up. Well, in GERD, one of the common reasons is that gate is not functioning properly.
Okay.
And there's different components to the gate. And one of them is really the way the stomach is sort of shaped on the inside.
Okay.
And as that shape changes over time, either due to just simply aging, pressure from heavy exercise or lifting, pregnancy is a common time where there's a lot of external pressure, that gate can become abnormal.
Okay.
And so if we can switch to the video here.
Yep, we'll go ahead and-
we'll take a look at how the procedure itself works. Think about it as repairing the gate.
Okay.
So here you can see the device is passed into the stomach with the camera passing through the device. So the operator is controlling it. And here we're using the device to simply grab your own tissue back down to kind of recreate that gate, if you will. And so we're taking the junction between the esophagus and the stomach, we're reducing it down. I like to think of it as sort of creating a funnel shape, where the esophagus sort of narrows within the stomach. And so if you start to think about it, as acid comes up, it's going to be deflected around this as opposed to going straight up.
Sure.
In order to keep things in place, the device sort of functions as a stapler, and we're using these safe fasteners. As you can see here, those are the blue on the picture. And what these are going to do is promote the tissue to come together and stay together. The fasteners don't need to be removed. They're designed to stay in there. Some will pass on their own, but really what you see is happening is the tissue is fusing together with time.
Right.
And so if you can imagine it from the perspective of, if you're the acid in the stomach and you're trying to go up, instead you're going to get deflected off to the sides.
Sure.
And that now becomes the new gate that's preventing reflux.
Beautiful. Perfect. Thank you for that. So the other component of the Tif procedure oftentimes is also the hiatal hernia.
Yes.
Correct.
So I'm going to let you, Dr. Heidi, explain that. We don't have an animation for that.
No.
But
So,
you can talk through it. Yeah.
So when the esophagus passes through the chest to get into the abdomen, it has to pass through the diaphragm. And there's an opening in the diaphragm called the esophageal hiatus. And what we learned back when we were doing laparoscopic surgery for reflux is that diaphragm opening's got to be small enough so that the stomach doesn't slip up into the chest. When it dilates and the stomach does slip up into the chest through the hiatus, we call that a hiatal hernia. the stomach is herniating through the hiatus. And when that happens, the pressures that we use to breathe, which are negative pressure, they open that junction instead of closing it. Below the diaphragm in the abdomen, it's positive pressure and helps that gate close. So if you have a hiatal hernia, we have to fix that first for the gate to work. So we do that with little incisions, laparoscopically go in, 2 incisions under each rib cage. We pull the stomach down, sew those muscle structures back together. So they're too big, we sew them down to a slot just the size of the esophagus. Now the stomach underneath can be folded up onto the esophagus with the Tif device, recreating the valve or the gate, and then that completely controls reflux.
Perfect. That was a great. I like the gate
it's a good concept.
analogy. Yes. So let's talk a little bit about. There's some questions that always come up. Do I go see a GI specialist? Do I see a general surgeon? Who do I see to potentially get the Tif procedure? So maybe explain how that works for you, Dr. Heidi. You can do both, right? You can. Right.
So with general surgery, we operate a lot in the abdomen, and so we have to be able to evaluate the esophagus, the stomach, even the colon. And so we're trained to do endoscopy as well. So you could come see a surgeon who at least works in that area, works in the reflux arena, and they can do endoscopy and workup as well as doing the Tif and the hiatal repair. On the other hand, you could see a gastroenterologist. They spend the majority of their time doing endoscopy and doing those sorts of diagnostics. And if you just need a straight Tif, they can do a straight Tif. If they find a hiatal hernia, they may partner with their surgeon.
That's right.
And the surgeon will repair the diaphragm, and then the gastroenterologist can do the Tif. So it's something that brings 2 specialties together.
That's right.
Yeah, perfect. Thank you. Before I'm going to ask you if we have got questions, but before we do that, I do want to just touch on the clinical studies or the papers that were kind of written. We've got at the Tempo and the Respect that kind of talk about the Tif procedure. Do you want to touch on that a little bit at all? Or?
Sure, I can start with maybe the Tempo study. So, it may seem obvious that when we do something and it works, that we assume that it's because we did something. And in medicine, we have to keep a little bit higher standards and really prove cause and effect. And we do that by conducting research studies or clinical trials. And this is where we take a patient who has a condition, we offer the treatment that we're studying, and then we compare it to basically what would be the standard of care or their current treatment. Right. And it's important when you're maybe interpreting the results or reading about it, there's a few things that I look for to decide was this study really support what I'm trying to accomplish? Right. And one of the strongest types of studies is what's called a randomized controlled trial. And that's where patients are randomly assigned to either receiving the treatment or what we call placebo. And that really takes out a lot of the bias. If I were to decide one person gets it versus another, I may be introducing a subtle bias, and that could throw off the results. Yeah. So when we're looking at studies, we give the most value or respect to ones that are randomized control studies. And that's what one of the early studies on Tif called the Tempo study was. The second thing we look at is who were the patients that were studied. If you're going to study the procedure in a subgroup of patients, if you go to treat patients, if they're not in that subgroup, it's going to be hard to make the connection. Sure. And so what was well done in this study was they selected patients based on what we discussed, was their symptoms. And they used, similar to the scoring system we used, patients who were having troublesome regurgitation and or heartburn as their criteria. Now, we did confirm that they had acid reflux, but the primary goal of the study was, will this procedure help your symptoms? Okay. And that may seem obvious, but often studies are designed sometimes to meet maybe what we think it's going to do, not really what it needs to do. Right. And in this study, the authors did a good job of selecting the important endpoint. So with that said, the study randomized patients to receiving either the Tif procedure or just staying on what was considered maximum dose antacids, which was the alternative.
Yeah.
And they studied these patients up to 5 years after their procedure,
Right.
And published those results in 2018. And this was really a turning point in the field because what it showed was, Tif worked considerably better than just maximum therapy. And more importantly, it lasted during those 5 years.
Yeah.
So what we see even 5 years later is 80% of patients are free of the original symptoms that
Yeah.
they came to see their doctor for. So really important trial, and as we've seen, the use of Tif has really accelerated since the publication of that study.
Yeah, perfect. Thank you. Anything else to add in regards to those? Or do you want to start talking about your latest pH paper and CTIF?
Well, I think one of the aspects that he was talking about, patient selection, was that when they were doing these two trials, Tempo and Respect, they were at a period of time where we were trying to get an understanding of when should we repair the diaphragmatic defect, the Hiatal hernia, with Tif. And so those patients weren't really offered Hiatal hernia repair. Subsequently, I had collected data on patients that I was seeing, and I was doing Hiatal repairs and Tifs. And so then we used the pH study
Right.
in order to see, well, is it really better? So on one hand, you have symptoms, which is what we feel, but on the other hand, you have the pH test, which gives what we
Physical,
call objective data. We have a number that we can look at and say this is normal or this is abnormal, and there's a line between. So we tested pre-op and post-op acid levels, and what we found is at 6 months, if we went and we looked at the repair, the Hiatal hernia repair was intact and the fundoplication was intact, 95% of those patients had gone from abnormal pH scores to normal pH scores.
Oh,
And
yeah.
it wasn't average, 90%, 95% of those patients were normal
Yeah.
in the pH score.
That's
So it's
great.
an objective way of saying, yeah, this is actually working. We can measure it with a measuring device, a ruler, if you will.
Sure.
And it's actually working.
Yeah.
That's a great point. It brings up a critical point, which is the initial evaluation of the patient. If you've had a kind of a quick in and out endoscopy, or maybe not had the pH testing, you may overlook a hernia. And then
Yeah.
we see that. I think both of us have probably seen patients
Absolutely.
like that. And so, again, matching, the right therapy for the right patient, and that can be Tif alone, Tif with a hernia repair, or in some cases it won't be Tif at all.
Yeah.
And we have to recognize that as well. So that really getting a really detailed examination, evaluation from your physician at the beginning really will help you choose the right approach.
Right approach. Fantastic. Wonderful. So I suspect we have quite a few questions coming in. So Karen.
We do. We have a lot of questions. I'm going to start off. Christine is in Phoenix, and she suffers from hypothyroidism, and she takes medication, and she suffers from Gerd. What can she do to get relief permanently, or is Tif an option for her?
Yeah, that's you're in a big group of people who are in the same boat. And I think it's good to start thinking about long-term control of your GERD. And so, if we were to see you, I'd be, kind of like we discussed, doing an initial endoscopy to really determine, do you have a hiatal hernia? Sort of how much has that gate, like we discussed, has it separated or gotten loose? And then we can start talking about what the options are. Your hypothyroidism in and of itself, doesn't prevent you from getting treatment for your GERD, and we shouldn't just chalk it up to part of that condition. There may be some subtle interaction between the two, but honestly, I think I would treat you just like anyone else with GERD and do the same evaluation. And Tif may, in fact, be part of, maybe a good option for you based on the findings.
And one of the things to realize is if you have symptoms and you've been placed on the PPIs, proton pump inhibitors. That's maximal medical therapy. And so if you've been on that for a while, and we usually say 6 months, and things have not gotten better, or you can't get off the PPIs, then it really is time to come in and be evaluated.
Yeah, perfect. Thank you.
Perfect. So we have Patty, who suffers, she says, really badly from GERD. She takes 40 milligrams PPIs twice a day. She has a Hiatal hernia, and she has started hiccuping 1 to 100 times a day. Nothing's helping. Would the Tif procedure help with that?
She probably needs a hiatal hernia repair with the Tif. A lot of times that stomach will get caught in the diaphragm, and that'll trigger the hiccups. And there are other causes for hiccups, of course, but getting the stomach out of the diaphragm, repairing the diaphragm, and then doing the Tif would probably be the sequence of procedures that I would recommend.
Perfect, perfect. And we have a lot of people that are just commenting that they are getting their pH and Bravo tests done, and they're very excited to see if they are candidates. We also have Linda. She has a constant postnasal drip and was told that the acidity is from her esophagus, and that her larynx is very swollen. She has a lot of hoarseness and was put on a diet of smoothies. And
Sounds good.
there's been no improvement. She's tried to eliminate the trigger foods, and is there, I guess, is Tif an option for her, or is there something that maybe else that she could do?
Now, this is kind of the segment that we call laryngeal pharyngeal reflux, or LPR. And the problem is there's no direct test for that. You have to look for the typical reflux symptoms, prove that using the diagnostics, and in particular the pH test is important to be sure that we're speaking the same language. And then if that's positive, you can have the reflux controlled, and there's about an 80% correlation with improvement of LPR symptoms. The other thing about LPR is it's a chronic inflammatory state, and it takes about a year for the inflammation to get better. So a lot of people with heartburn and regurgitation will be better the next morning.
Yes.
But patients with LPR may need to wait about a year to see how good is it going to get.
Interesting. Anything else to add, Dr. Patel?
No, that's a great point. I try to think of it as, again, we discussed the issue really is at that junction. That's where the crux, where the condition starts. And the further away you get from that, we have to be a little more careful of attributing cause and effect.
Okay.
And so it's not to say it can't be improved, but we do have to think carefully and not sort of over-promise the further away you get from the target.
Okay.
Yeah.
Perfect.
We have one more for this segment, but Ramon says, I had the Tif procedure on June 3rd, and I feel like I have a mucus or saliva in my throat sometimes. Will this go away, and is this normal?
6 months?
June 3rd.
June 3rd. So this is just
Yes,
around
June
the
3rd.
corner,
He just
basically.
had.
Well, the body does produce saliva and mucus when you have chronic reflux. It's a protective mechanism. It helps neutralize some of the acid that's in the esophagus. So this may be a persistent symptom of the chronic reflux. And it may get better with time as the esophagus heals and you're recovering from the chronic exposure of acid to the esophagus.
Yeah, one of the things I think we see also is, when we're, as you saw in the video, we're kind of pinching the stomach a little bit at the top. And so for a little bit, the stomach has to kind of get used to that new shape. And so you may have a little increase, belching air kind of gets in the little crevices there. And that could kind of produce a little bit of this sort of belching, a little bit of discomfort. Give it a few weeks and it typically tends to improve.
Fantastic, thank you. So the next thing I want to talk about is durability. We did discuss the Tempo paper a bit about the 5-year durability. Talk to us a little bit about the durability of the Tif procedure. Yeah, I'll just.
I love your tire analogy.
Yeah, the tire analogy.
The basis of durability came really when we were doing laparoscopic fundoplications, and people would have recurrent reflux within 6 months, but then a population would then over time have recurrence. And so what they determined is you really need to have 5-year studies determine in whole how many people are going to, have reflux come back, right?
Sure.
And so the tempo's a 5-year study, and that's really what it's designed for. And what it showed is stability from year 1 to year 3 to year 5, in that you get past that 6-month segment, and most people are very stable. When people ask me, well, is this going to last the rest of my life? I always chuckle a little bit to myself, because there's nothing in life that lasts forever, right? And what I tell them is it's a little bit like buying a new car with new tires. You have to take care of the car, you got to take care of the tires. If you're peeling out at every stop sign, you're going to wear out your tires, you're going to have to get new tires. Same thing here. There are some things that I think can wear out the repair. Carbonated beverages is one that I think is pretty significant because it overbloats the stomach. And also heavy lifting for the Hiatal repair. That seems to be the theme when people say, well, I was moving hay, or we live out in the country, or
so
bags
Texas.
of grain, right? I felt kind of a pinch, and then the next day the reflux came back.
Yeah.
Well, you have to watch out for those two things in particular, or you can have a recurrence. The nice thing is it's fairly easy to repair.
Right.
We don't alter a lot of anatomy. There's not a lot of scar tissue. It's easy to go back in and re-repair it.
Sure.
You don't want to have to do that. So you want to take care of your tires, take care of your Tif and your Hiatal repair. But if we have to, we can, and it's not difficult to do.
Yeah, and then I wanted you to show this, because we were talking about this earlier, the graph.
Yeah, so just going back to, the question is, what exactly are we treating? Yes, we're treating GERD, but from, your experience or a patient's experience, it's the symptoms and the impact on the quality of life. And so we measure that with the questionnaire, and then we really there's not a one and done perfect quality of life. It's an improvement, and so what I really discuss is we can sustain this improvement rather than sort of saying that we're going to eliminate the condition.
I like that.
And I don't know if you can see here, if you look at this simple, I told you I'm simple, the simple diagram, simple diagram here, this blue line is just tracking the Gerd Hercule score before the procedure, and then at 2, 3, and 5, and even now, some of those patients from the original study have made it 10 years. And what you can see is a high score means a lot of symptoms, which all of the patients started off at. And then after the procedure, you see this marked reduction. Now, it doesn't go to 0, right?
Right.
So just like when you're treating high blood pressure or diabetes, you don't go to normal, but you have an improvement.
Right.
And in the same way here, we see this marked improvement, and with time, we see it stays improved. So this is really what I think is really highlighted the durability in the improvement of your quality of life.
Yeah, that's perfect. Thank you so much. Last thing I wanted to touch on is we get lots of questions about the comparability of the Tif procedure and other anti-reflux procedures. Maybe you can talk a little bit about that.
Yeah, historically, we started out with open procedures, and of course, only the worst patients would get that. And then when we got to laparoscopic surgery, it was right about the time where PPIs came to the market. And so there were some comparative trials between the laparoscopic Nissen fundoplication and maximal PPI therapy. And when they compared them, what they found is actually surgery did better at controlling the symptoms than the PPIs did. But the problem was there were a lot of side effects to those surgeries. A lot of bloating, a lot of gassiness, trouble swallowing. And so the overall recommendation was, well, you don't want to have a procedure and then cause new problems, which really there isn't a fix for. You might as well stay on the medicines, right?
Sure.
So in particular, what drew me to Tif, as somebody who had been doing Nissens, was that when they started doing the TIFs, they noted that there was no post-fundoplication symptoms of bloat, gassiness, trouble swallowing. at least maybe you came in with some bloating. It wasn't any worse, and a lot of times was better.
Sure.
And that's borne out in all the multiple studies. I mean, there's hundreds of studies now that basically show that these procedures do not cause the problems that were associated with the older laparoscopic procedures, which is one of the reasons why we use this. Is it's superior in terms of side effects to the older procedures. And then along the way, what we also identified is that it's much safer. It's about 6 times safer to have a hiatal hernia TIF or a straight TIF than it was to have a laparoscopic Nissen fundoplication.
Sure.
So safety is a major selling point
Right.
for a lot of the physicians and a lot of the patients.
Fantastic.
Yeah,
Yeah.
and from a gastroenterologist standpoint, there's been a handful of other endoscopic or scope-only therapies that have come and gone.
Sure.
And primarily was a few issues. One is they weren't as effective, or the effort wasn't put in to demonstrate the effectiveness, like
Okay.
the studies that we discussed
Sure.
earlier. And number 2 is, again, safety is foremost. Where we're treating, for most patients, this is a quality of life condition we're treating.
Right.
And we have to maintain that safety profile. Otherwise, we could actually make the quality of life worse. And so there were concerns with some of the other options that have been tried. But now I think with the thousands upon thousands of patients who've undergone TIF, I think the safety profile is very clear and favorable.
Fantastic. Thank you. We're going to see if we have any other questions before we conclude.
We do. Margaret has a question. Does fixing the hiatal hernia take care of my GERD? And if it does, do I still need the Tif procedure?
So that's a good question, and it's been asked multiple times, and over the years, that's been studied multiple times. And so the answer is you can't just do one or the other. So for instance, if you have a TIF, but you had a hiatal hernia, about 50% of those patients are going to become symptomatic again within 6 months. Same thing as if you do a hiatal hernia repair, but you don't do any fundoplication, 50% of those patients remain symptomatic. So you have to do both. Both structures are necessary for that gate or that door or valve to function properly.
Yeah.
Perfect.
Wonderful. Margaret has an additional question. Do any of these surgeries make your stomach smaller? It sounds like it does, or is your esophagus smaller?
No, it doesn't make either smaller. The stomach is the same volume. It's more about form and function. If it's in the right form, if it's in the right position, that valve works normally. And that's really what we're doing, is we're pulling the stomach back onto the esophagus where it originally should have been.
Okay.
There's actually several questions regarding LPR. Just wondering if they're still a candidate for the TIF procedure if they have LPR, and will it help?
So the first thing is to take the Hercule score and the RSI and see if you score positive on those. Then you need a workup, the endoscopy, pH testing, to confirm that you have reflux. Then if you do have reflux, you have to correlate the symptoms to the typical reflux, right? Again, there's no direct test to say, yes, the LPR symptoms, usually cough, clearing of the throat, hoarseness, those symptoms are absolutely caused by reflux. There isn't a test that tells you that. It's more of a correlation.
Okay. That makes sense. Anything to add on that?
Well, no, I agree with that. And one little clue could be, however, if you do have relief of those symptoms with an antacid, that gives us a little clue that perhaps controlling the acid will ultimately help.
Yeah, those patients typically do better if they're controlled with those medicines.
Okay.
Wonderful. And then Lori's asking, since a surgeon or a gastroenterologist is using the esophagus device for TIF, will the results be the same?
That's a good
So
question.
the results the same whether or
We
not?
can arm wrestle now.
I mean, I think one of the problems with laparoscopic fundoplications were they weren't very reproducible.
Correct.
Different surgeons would go in and they would wrap it differently, more or less length, more or less circumference. What has happened over time, and there has been an evolution in technique, what we know. There's also been an evolution in the device.
Yes.
And the device they have now is more automated, and it really is reproducible.
Yes.
You get the same looking valve every single time. And so, yeah, it is equally effective in a surgeon's hands or a gastroenterologist's hands. The difference is you need a surgeon to repair the hiatal hernia.
Correct.
And then they can turn it over to the gastroenterologist to do the TIF part, and you'll have a fantastic outcome.
Yeah. Anything else to add?
Yeah, no, you know, as gastroenterologists, you know, we actually, you know, doing this procedure has sort of allowed us to think more like a surgeon.
Yeah.
You know, I think we've developed a greater understanding of this complex area, and as such, we also are more familiar with the limitations of medical management.
Sure.
And so we sort of bring that you know, lens to it as well. And so I think, you know, you're in good hands in either scenario. If someone is offering to do TIF, they also have gone through a fair amount of training.
Right.
And you know, there is a training program. You know, we often will use models and so on to train new physicians in it. So you know, it does require some additional skill sets and expertise that are developed. So if you're seeing someone who's offering it, there's a good chance, regardless of if they're a surgeon or a GI, that you'll have a good outcome.
Yeah.
Fantastic. Thank you.
Let's see. Dina is wondering, she has a 2-centimeter hiatal hernia. Is that too small to be repaired?
So the hiatal hernia is measured a couple of ways, and 2 centimeters seems to be the breaking point. So 2 centimeters may be how tall it is, or it may be how wide it is. Generally, if it's 2 centimeters or less, we don't repair it. If it's 2 centimeters or more, then we do repair it. So it really does need a thorough evaluation. There are ways of measuring it and to get a very good understanding about the way it was measured so that you know for sure what the size is. But if it was 2 centimeters, I would do a straight TIF.
Wonderful. And then Wendy is wondering, do patients come to your practice directly for GERD evaluations or via their healthcare providers? Is there a recommended process, and can you share how you manage your patient care together?
Well, for a surgeon, they're usually referred from a gastroenterologist
Right.
if they don't do TIF, or from primary care. It's not common that the first stop is at a surgeon, right?
Sure.
We're a little further down the line. But gastroenterologists take the brunt of the reflux patients.
Yeah. Yeah, so it's not uncommon to be seen either referred from primary care, or I actually do see a lot of patients who, through their own research, discover our practice and come see me for this. And so, regardless, once you're here, most patients will undergo, if they haven't already, sort of the diagnostics we discussed. I like to kind of combine them into as few procedures as possible. So we're lucky here. We have an efficient unit where you can come in the morning. We didn't talk much about it, but often you'll also have a function of, or a test to measure the function of the esophagus. It's called a manometry or motility study. So we'll have that done in the morning, and a couple hours later I'll do the endoscopy, take all our measurements, and then place that pH meter at the end. So try to consolidate that into one visit, and then review that and make a treatment plan.
Perfect.
Wonderful. And Lori is wondering, what is considered a high level of pH acid for a Bravo test?
So the pH isn't a straight number. It's actually a composite score of several different things. And so 14.7 is considered the break point, because having some acid in the esophagus is normal. It's a defense mechanism against bacteria and fungus and that sort of stuff. So having a little bit in the esophagus is normal. But if your composite score is more than 14.7, that's considered abnormal.
Okay.
And then our last questions that we have a ton asking about insurance. Is this covered by insurance?
I'll let
Yeah, I mean, of course, each plan is unique in their own way. But one of the things that came out of, again, showing the power of well-done clinical trials is once the results of the Tempo study were published in 2017-18, you saw a major shift in the insurance companies. And of course, one of the first events was Medicare put this under their approved procedures list based on the quality of that research. And once that happened, a lot, if not most, insurance companies have followed suit as well. So sometimes you may just need to make sure you've provided the diagnostic testing accurately. But I don't know about you, I really haven't had much of an issue in the last couple of years.
No,
with
once Medicare approved it, it moved forward pretty quickly.
That's right.
And I can't think of somebody in the last couple of years that wasn't covered.
Yeah.
Fantastic. Wonderful. Well, thank you, Karen. And then before we end tonight, I do want to give you both the opportunity to maybe give a little advice that you would give patients that are suffering, that are watching tonight. What would that one thing be that you would tell a patient to do? I'll let you go first. Dr. Patel.
Yeah, I saw someone like this morning in my practice, and she said, "Well, I've just been dealing with it for 20 years."
Yikes.
And my advice would be, if you're dealing with it, don't wait 20 years.
Yeah.
And although, again, we've kind of come to normalize heartburn, it doesn't need to be normal. It doesn't have to be a normal part of your life. And there are safe, effective ways to treat it that really can improve, lots of parts of your life you may not even realize. This patient I saw today, she wakes up during the night from her reflux. She's never well rested, and that has a domino effect, throughout the day. So, take your heartburn seriously and see if we can help.
I like that.
I think
Heidi?
what I would say is that, the medicines are very powerful and they're very good at controlling symptoms, and they're also over the counter.
Right.
So a lot of people are self-treating and they never get evaluated. If you've been taking those medicines more than 6 months, you need to have an evaluation. Because one of the only cancers in the United States that's increasing in incidence
That's a good point.
is esophageal cancer. We think it's because people are treating themselves and not getting evaluated ever.
That's a
Right?
really good
And so because it's so easy to get the medications, like you said, they compensate for the symptoms they're having, and they wake up one day, it's 20 years later. So don't do that. If you've been on the medicines for 6 months, go get an evaluation.
Yeah. Perfect. Well, thank you so much to both of you for being here with us this evening. Before we conclude, I do want to remind everyone, well, if you're obviously in the Houston or Bay City area, you can see Dr. Heidi and Dr. Patel. However, if you are not in the area, you can go to GERDhelp.com. We do have a physician finder there, and you can put in your zip code or your state, and you'll be able to find a TIF-trained physician near you. In addition to that, we have a lot of tools that provide, as Dr. Heidi and Dr. Patel were talking about, the Hercule Questionnaire. If you just go to our website, GERDhelp.com, we do have that Hercule Questionnaire on there that you can take. In addition to that, we have a new GERDhelp mobile app. It's free. You just download. It was on the screen before, and we'll put that back up there. But you can scan that and or look for it on your app store. It's just called GERDhelp. There's lots of resources and tools in there. It also has the questionnaire that they would just discuss. It talks about everything about GERD, articles, also some diet and recommendations on there. So. Lots of tools. So as both of you physicians said, don't wait. You don't have to suffer any longer. I feel like they're talking to me every time. Go get checked. One day you'll see my EGD live on Tif Talk sometime. No. But thank you again for joining us again. We really appreciate it. I hope all of you that are watching enjoyed this. We went a little more clinical today than usual. Thank you, Karen, for being here as well. Thank you again. We're always here on Tuesday nights, so please catch us next Tuesday for our Tif Talk. Have a great evening. Thank you.